had in body lice are person-to-person contact, takes reasonably prolonged person-to-person contact, body lice being the ones much more linked to disease that then becomes a huge public health concern. Patients with body lice are likely to present with generalized pruritus, and on inspection of the clothing, they then will have lice and nits in the clothing.
That was Dr. Dirk Elston talking about how to identify and manage human body lice manifestations. Welcome to episode 58 of Dermatology Weekly, where we bring you the latest in dermatology news, followed by a peer-to-peer conversation with clinical and research experts in the field of dermatology. I'm the voice of MDEdge Podcast's Nick Andrews. Coming up later, Dr. Elston joins Dr. Vincent DeLeo to discuss body lice manifestations in the peer-to-peer segment of Derm Weekly. You can find more information about either Dr. DeLeo or Dr. Elston by clicking the link in the show notes. Before we get to peer-to-peer, here's what's new in dermatology. iPLEDGE will allow at-home pregnancy tests during the COVID-19 pandemic, and there are new recommendations for how to treat non-urgent skin cancer during the pandemic. But we begin today with cases of skin manifestations emerging during the COVID-19 pandemic. In Alessandro Manzoni Hospital in Italy, researchers report skin manifestations in about 20% of patients with COVID-19. This is according to a report accepted for publication in the Journal of the European Academy of Dermatology and Venerology. Of the nearly 150 patients with COVID-19, researchers excluded those patients who had started new drugs 2 weeks prior so as to rule out acute drug reactions. The researchers found that more than 20% of the 88 COVID-19 patients who qualified observed at the hospital developed skin manifestations. 8 of these patients had skin eruptions at symptom onset, while the remaining 10 patients had symptoms develop after hospitalization. 14 patients had red rashes, 3 had widespread urticaria, and 1 had vesicles similar to chickenpox. The most commonly affected area was the trunk. Itching was mild or absent, and lesions usually healed in about a few days. The most important fact? Skin manifestations did not correlate with disease severity. A report from Bangkok shows how COVID-19 skin manifestations can cloud the diagnosis, according to the authors. In this report, authors described a case of COVID-19 infection in Bangkok that masqueraded as dengue fever. A patient there presented with only the following symptoms: a skin rash, petechiae, and low platelet count. The patient was diagnosed with dengue fever. The patient was eventually re-diagnosed with COVID-19 at a tertiary care center after being admitted with respiratory problems. Dr. Randy Jacobs is an assistant clinical professor of dermatology at UC Riverside, who is also in private practice. Dr. Jacobs told MDEdge that COVID-19 can feature signs of small blood vessel occultation. These can be petechiae or tiny bruises, and transient livedoid eruptions. Dr. Jacobs had a 67-year-old patient who presented with a low fever, nasal congestion, postnasal drip, and a wet cough, but no shortness of breath. It looked like a common cold. But a week later, the man had a non-pruritic blanching livedoid vascular eruption on his right anterior thigh and blood in his urine, and he felt weak. The vascular eruption and bloody urine resolved in 24 hours, but the COVID-19 test came back positive, and his cough became dry and hacking, and the weakness persisted. Dr. Jacobs said that this suggests vascular occultation. It's still unknown whether it's neurogenic or microthrombotic or immune complex mediated. The important thing is that this is a skin finding that can help clinicians as they work up their patients with COVID-19 symptoms. And there is new guidance on non-urgent skin cancer care during the pandemic. The National Comprehensive Cancer Network released a new document instructing clinicians to defer therapeutic lymphoidenectomy for stage 3 melanoma. Instead, the document notes to opt for treatment with checkpoint inhibitors or BRAF/MEK inhibitors, except when the metastatic nodes are threatening vital structures or neoadjuvant therapy is not possible, or neoadjuvant therapy has already failed. You can find the entire document by clicking the link in the show notes. The NCCN melanoma panel does not consider neoadjuvant therapy as a superior option to surgery followed by systemic adjuvant therapy for stage 3 melanoma. However, available data suggest this is a reasonable resource-conserving option during the COVID-19 outbreak. The panel notes that surgery should be performed 8 to 9 weeks after initiation. The advice on melanoma echoes advice from other medical fields. The recommendations focused on deferring non-urgent care until after the pandemic passes, and in the meantime, limiting patient contact with the medical system while preserving resources by using tools such as telemedicine. In a separate document on non-melanoma skin cancer, the group said that the excisions for NMSC, or non-melanoma skin cancer, should also be generally postponed during the pandemic. This includes basal and squamous cell carcinoma, dermatofibrosarcoma, protuberans, and rare tumors. The exception to this is Merkel cell carcinoma. The exception is that if there is a risk of metastases within 3 months. However, such estimations of risks should be weighted against the risks of the patient contracting COVID-19 infection or asymptomatically transmitting COVID-19 to healthcare workers. You can find the complete document and recommendations for various types of non-melanoma skin cancer by clicking the link in the podcast notes. And finally today, patients who are taking isotretinoin can use telemedicine to meet with their prescribing physicians instead of an in-person visit, and female patients can use at-home pregnancy tests to comply with the requirements of the iPLEDGE program during the COVID-19 pandemic. This is according to a new update, which is on the iPLEDGE website. You can read the update and the accompanying story by clicking the link in the podcast notes. The change follows recent guidance from the Department of Health and Human Services and the FDA regarding accommodations for medical care and drugs subject to risk evaluation and mitigation strategies in the midst of the public health emergency that requires most people to remain in their homes, except for essential services. Dr. Neil Goldberg is a dermatologist in Westchester County in New York. He said that allowing female patients to take at-home pregnancy tests and communicate the results to their physician according to their preference is a game changer in the middle of a pandemic. He said that these patients who don't need to spend time outside just to get pregnancy tests done, it makes it a lot easier. Despite this, Dr. Goldberg expressed his frustration that these accommodations have not been more widely publicized. In fact, he only discovered these changes incidentally when he was speaking to an iPLEDGE program representative to request a waiver for a patient. He said, quote, "The size of your notice should be proportionate to how important it is." The iPLEDGE program is designed in part to ensure unplanned pregnancies do not occur in females while taking the teratogenic acne drug. Stick around after the break for Peer-to-Peer with Dr. Vincent DeLeo. Welcome back to Dermatology Weekly. I am Nick Andrews. It's time now for Peer-to-Peer.
Today we're talking about managing human body lice with Dr. Dirk Elston, who is from the Medical University of South Carolina in Charleston. Thank you so much for joining us today, Dirk.
You're welcome. My pleasure.
So let's get started. How do head lice and body lice differ?
They look very similar, although the nit is at more of an obtuse angle from the hair in the body versus the head louse. But the body lice tend to lay their eggs in seams of clothing and on the fibers of hair in clothing rather than on the hairs on the head. So similar in appearance, whereas pubic lice differ in appearance. Some differences in the nit case, but the more important thing is just where are they infesting? Clothing versus human hair.
Good point. How are body lice transmitted and where are outbreaks most likely to occur?
So both head and body lice are person-to-person contact. Takes reasonably prolonged person-to-person contact for them to spread person to another. Mass crowding situations, refugee situations, poverty, homelessness, those are all things that contribute to the spread of body lice. Body lice being the ones much more linked to disease that then becomes a huge public health concern.
So how will patients with body lice present in our clinics?
Patients with body lice are likely to present with generalized pruritus. They will often have the maculated ceruleae, which are bluish because of Tyndall effect, hemosiderin deposits in the skin where the lice have fed, and on inspection of the clothing, they then will have lice and nits in the clothing.
So once we make the diagnosis, is pharmacologic intervention necessary for body lice?
Body lice can be treated entirely with treatment of the clothing, whereas head lice require treatment of the human being or shaving of the head. The pharmacologic intervention in the case of body lice is more for disease that the body louse may have spread. So endocarditis and typhus type organisms that are spread. The cat scratch fever organism, when spread by a louse, is an important cause of endocarditis among the homeless in America and elsewhere.
So, Dirk, what should we be looking for when we see a patient with body lice, considering what you've just told us about the other conditions that might be spread with it?
Signs and symptoms of sepsis or more serious infection. Typhus, similar to typhoid, presents with rose spots. There may be an eschar at the type, as with other rickettsial-type diseases. The endocarditis is the cat scratch type organism, which when transmitted by a flea on the cat gives cat scratch disease, and when transmitted by the louse causes endocarditis. So acral splinter hemorrhages, presence of Osler-type nodes, other signs of sepsis would all be important. Most of these patients won't present to us in clinic, but more likely to emergency department.
That's very, very interesting. So what about head lice? How do you treat head lice, especially for families who are looking for a more natural option, which a lot of people are these days?
Head lice are widespread. They know no economic or social boundaries. So they're in nice suburban schools as well as inner city schools, rural and urban areas. Fortunately, they are not known to be significant vectors of disease, but they are certainly a nuisance and something that carries a significant social stigma. Shaving of the head does work, but few parents are willing to do that. Older treatments, pyrethroids, still have some efficacy, but there is a lot of resistance to pyrethroids and also to malathion. There are also some concern that repeated use of pyrethroids has been linked statistically to childhood leukemia. So that certainly repeated exposures would be something we would want to avoid if possible, especially in the face of resistance where they're not likely to be effective anyway. Newer entries into the market include benzyl alcohol. Benzyl alcohol stuns open the respiratory spiracle so that inert ingredients can plug it and the louse asphyxiates. It appears to be effective both against the adults and the nits, which the nits and ova are relatively resistant to most of the pediculicides that would be used, but benzyl alcohol does appear to have efficacy. Spinosad, which has been marketed, especially in Canada, as a so-called natural soil-derived insecticide. The vehicle contains a significant amount of benzyl alcohol, and it's unclear whether the active ingredient or the benzyl alcohol is really involved in the efficacy of that agent. Inert agents by themselves, things like Cetaphil, have been tried, but without the benzyl alcohol, they really don't do very well to asphyxiate the lice.
Now that we've talked about diagnosis and treatment, any thoughts about prevention for our patients?
I'll make one more comment about treatment before we move on to prevention. Important for parents to know that the so-called bug busting, where they try to comb through the hair, the efficacy rates are really quite low, and it takes multiple episodes of combing through the hair multiple times a day Children tend to resist this procedure, and it's not very efficacious. The various combs that have been used, marketed, electrified combs that supposedly create a plasma field, again, limited data on efficacy. In terms of prevention, especially in the classroom, if you walk into most classrooms, especially in wintertime, all the coats and hats are in a pile in the closet because the kids aren't very good at hanging them up. It's best for them simply to come into the room and everyone puts their hat and coat, their personal belongings under their desk and keeps it there until the end of the day. That simple separation of the clothing is the greatest intervention that we can do to prevent spread among school children, and it's really a very simple and common sense thing to do.
So, anything else you'd like to add to this discussion, which has been really enlightening? And I would recommend everyone go to your article to get other advice. But anything you'd like to add at this point?
The last thing would be that if a patient has very tight curly hair or coarse curly hair, pubic lice are more likely to infest the scalp than head lice in that particular texture of hair. And so in that case, you look not for other infected children, but for an adult with pubic lice who may be the source of infection. Pubic lice in adults often presents with generalized pruritus, and commonly a wide infestation in body hair, especially in males, not just restricted to the pubic region.
That's good advice. So, Dirk, once again, we'd like to thank you for joining us today, and hope you have a good day.
My pleasure. Thank you very much. Bye-bye.
And that concludes episode 58 of Dermatology Weekly. Let's get to this week's credits. Dermatology Weekly is produced by MD-Edge editors Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of the show is produced by Melissa Sears and hosted by Dr. Vincent DeLeo. The news portion of Dermatology Weekly is produced by Elizabeth Meshkati. Stories in episode 58 were published online at mdedge.com and were written originally by M. Alexander Otto and Tara Haley. All MD-Edge podcasts are produced by MD-Edge and Medscape Editor-in-Chief Dr. Ivan Oransky. All MD-Edge podcasts are produced by MD-Edge executive editors Kathy Skarbeck and Mary Ellen Schneider, as well as multimedia editor Terry Rudd. Social media for Dermatology Weekly is produced by Kyla Clark. Dermatology Weekly is edited, engineered, and produced by Tyler Mundak. For all of us here at MD-Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.